Good evening and welcome to Freedom is a Constant Struggle with your host and producer, Kilu Nyasha, on this January 7th, 2016, the first show of the new year, with your host and producer, Kilu Nyasha, and at the controls is Andrew Montoya. Before I go to introduce my guest, I want to share with you a little housekeeping. Oh, where is it? I'm good at this, not finding things when I should. Oh, goodness, where did it go? Oh, my goodness, I'm so bad at these computers. I was messing around earlier, and here it is. The Oasis Clinic in Oakland that treats patients with hepatitis C is calling for a demonstration to protest the outrageous price gauging of big pharma corporations, which hike up the cost for essential life-saving medications such as the cure for the deadly hepatitis C virus in order to reap huge profits. The Oasis Clinic's demand is public health, not corporate wealth. The Labor Action Committee to Free Mumia Abu-Jamal urges you to support this demonstration, as many as 700,000 prisoners are among the nearly 5.2 million Americans infected with HCV, according to the Center for Disease Control, and political prisoner Mumia Abu-Jamal is among them. So mobilize at 12 noon, Monday, January 11th, at the J.P. Morgan Healthcare Conference being held at the St. Francis Hotel at Powell Street, Union Square, San Francisco. That's Monday, January 11th at noon. Be there. And so now I want to go to talk a little bit, explain to you. My guest is a past president of the Physicians for a National Health Program, a national nonprofit organization of 20,000 members based in Chicago. More and more physicians, health professionals, medical students, and patient advocates are standing up for single-payer national health insurance. My guest, Dr. James Kahn, and I will be discussing universal health care or single-payer health insurance, or Medicare for all, of the Affordable Care Act, also known as Obamacare, and associated issues. James G. Kahn, MD, MPH, is a past president of the California chapter of Physicians for a National Health Program, and currently, oh God, I'm going to learn how to use these computers, and currently professor in the Philip R. Lee Institute for Health Policy Studies, Global Health Sciences, and the Department of Epidemiology and Biostatistics at UCSF, that's the University of California at San Francisco. He leads two core economic courses there, Global Health Economics and Decision and Cost Effectiveness. Founder and director of the UCSF Global Health Economics Consortium, Dr. Kahn is an expert in cost-effectiveness analysis and has been widely published in journals such as the British Medical Journal on the cost and cost-effectiveness of HIV prevention and treatment in the developing world, as well as on other health conditions. Welcome, Dr. Kahn. It's a pleasure to have you, and I thank you for joining us.
Well, thank you very much for having me. It's a pleasure to be here.
Thank you. Why don't we start right off with talking about the cost, the administrative costs of Medicare as it now stands.
Well, as you know, this is a favorite topic of mine. The problem we have today in the United States, one of the problems we have with healthcare, is that we have an extraordinarily complex set of ways to pay for healthcare. We have Medicare, we have Medicaid, the Veterans Administration, and innumerable private insurance companies. What that means is that aside from many different participants on the payer side, each provider, so each doctor, each hospital, and so on, needs to deal with all of these different providers, each of which has different insurance policies and different rules about reimbursement. This creates quite a morass. And my colleagues and I recently looked at all of the research on this and tried to quantify how much we are wasting every year because of the unnecessary complexity of this system to pay for healthcare. And what we found is that we are wasting, well, there are many ways to put this number. My son, who's 16 years old and kind of helps me out sometimes, says, Dad, the best number is you're wasting $1 billion every day on unnecessary administrative costs in healthcare.
Wow,
that's about $1 trillion every 3 years. $1 trillion every 3 years.
Wow.
This is not how much we're spending to administer. This is how much we're wasting beyond what we really need to spend. If we took that money and put it into providing insurance and care for people who need it, we would solve the healthcare funding crisis right away.
Right. I mean, it's outrageous that that level of cost. And then the other thing is that doctors have to spend such a huge portion of a large percentage of their time doing administrative billing.
Exactly. In fact, that's incorporated into our number. But if you ask doctors now, particularly with the added complexity of the new electronic medical records, if you ask doctors how much time they're spending, they're basically taking their work home with them at night just so that they can finish the paperwork. And so the doctors are spending time is money, but they're also getting frustrated. And some of the best doctors are at risk of leaving medicine because they can't stand the paperwork.
And not only that, but the paperwork is even more cumbersome for Medicaid or Medi-Cal, as it is in California, patients. And so many doctors now really refuse to deal with it because it's so bureaucratic.
That's true. Medi-Cal, as it's known in California, is unnecessarily complex. I don't think it's necessarily a whole lot more complex than private insurance, which is pretty tough. But Medicare, which is the program for the elderly and long-term disabled, works better. It's a federal program. The rules are simpler. The paperwork's simpler. And as you said in the introduction, I work with an organization, Physicians for a National Health Program, that supports Medicare for all, taking the best of Medicare, improving it, and then making that our insurance system. Everyone in the same system, one single payer.
Right. Now, can you give our viewers an example of what you might consider the best healthcare system in the world? I understand France, for example, Sweden, Denmark, Britain.
Well, no, I'm not going to do that, because here's why. We have an organization of wealthy democracies called the OECD, or Organization for Economic Cooperation and Development. There is one country that stands apart from the rest, that distinguishes itself because of the nature of its healthcare system. That's not the country that's the best. That's the country that's the worst. That's us. All of the other members of the OECD have either a single payer or a set of rules that means that everyone gets exactly the same comprehensive health coverage, maybe through private insurers, but with controlled rates and very simple processing. So there's no one single best country. There are many countries that demonstrate day after day that you can provide high-quality healthcare with good outcomes at a cost that's anywhere from 1/3 to 1/2 less than what we pay in the United States.
Right. And what about have you studied the Cuban healthcare system at all?
I have not focused on the Cuban healthcare system. It has certainly, for a country that has the level of economic development that Cuba has, which is not high, they have an excellent healthcare system with very good statistics on health status, lots of doctors. In fact, Cuba exports doctors to many other countries.
Yes.
Unfortunately, one of the problems that some countries face is they will train, some poor countries will train doctors who then leave the countries and go work places which are more lucrative, like in the United States. And Cuba is doing the opposite. They're bringing doctors into the countries that are poor and need medical assistance.
Exactly. Yes. And they also export teachers.
Right.
But
and musicians. My boys are jazz musicians, and the musical talent of the Cubans is amazing.
I know. And it brings to mind what a young friend of mine said when she came back from Cuba. She was very young, and she said, I cleaned out my closet and got rid of a lot of stuff. She said, because when I was in Cuba, the young people, they didn't brag about what they had and the things that they had, the gadgets, the clothes, and so on. They bragged about what they did.
Well, I have to tell you a little story. It wasn't on our agenda for today, but my older son went to Cuba 2 years ago as a member of the jazz program at the Berkeley High School.
Oh.
And when he came back, I said, Eli, what was the week like? And he said it was transformative. He said these guys have nothing except the instrument in their hand and their clothes on their back, and they couldn't be happier. And they really committed to the music. So
Right.
It was an important lesson for him.
You're right. Yeah, they brag about their talents and their skills because they can be whatever they want to be in Cuba. They can study whatever they want to study. They really have free education culturally as well. So it's exciting. But let's get back to healthcare. Anyway, one of the things I wanted to also touch on was the ridiculous expense of hospitalization. I've been unfortunately I've had to be hospitalized numerous times between 1975 and 1980. I was in about 19 different medical facilities, from the best to the worst, ranging, and a total of 3 years altogether between in that 5-year period, 2 years consecutively. And I can honestly say that the healthcare system was terrible then, especially if you're indigent, and it's worse now because my most recent hospitalization, I was in an acute hospital that I had been in many, many years ago and had lived there for a couple of months, and the care is much worse today.
Oh, that
yes.
is an terribly unfortunate experience. I'm sorry you had to witness that, but what do you think's going on?
Well, they're cutting back. They're obviously cutting back on care. Mm-hmm. They don't give you the physical therapy that you anymore. That's not forthcoming, and there's just a general. I think the personnel seem to care less. The attitudes seem to be less caring. They're short-staffed, mm-hmm. And the rules have changed. Like they barely keep you clean anymore in hospitals.
So
without getting into details.
It sounds pretty terrible. I talked at the beginning about administrative costs, but there's another really critical piece to the need for health reform, and that is to let healthcare providers be enthusiastic, again, about providing care. Right now, there's so many things going on with healthcare that are undesirable, like cutting corners and the focused on corporate profits, an electronic medical record, which by all accounts is just terribly distracting, not well designed at all, and takes time away from patient-doctor interactions. A lot of providers, and I know doctors best, many of my colleagues talk about just how eager they are to get out of practice because it's no longer about the best parts of medicine. It's no longer about relating to their patients and about helping their patients. It's now about, filling in the blanks in these electronic records and moving people through these cost-cutting, but also, ironically, even efforts to bring more money into healthcare by paying for certain kinds of activities, like paying for if you do lots of a certain kinds of test, that can backfire too, because most doctors are in the business because they love being doctors, and as soon as you start making it into a pay for a particular thing, they start to get frustrated. And I think it's really important that we simplify and reform how we finance healthcare so that the emphasis can go back to the patient and the doctor and the other healthcare professionals.
Exactly. And the uh, the percentages that we spend on these well, let me back. I have a note here. It says Obamacare is really a compromise with the insurance industry and the drug industry, the people who've been running the healthcare system into the ground. So it would dump $1 trillion into the private insurance industry over the next 10 years, trying to get them to behave better. And in fact, the $1 trillion will give to private insurance companies, in a way, puts them in a stronger position.
Absolutely.
And for example, in Canada, insurance takes about 1% of running the system. In our system, it takes 14 cents for every dollar.
That's why we have this $1 billion a day that's wasted.
Exactly. Exactly what you said earlier. So it says you go to a typical American hospital, there are 150 people doing nothing but billing.
That's right.
Right.
Wouldn't we rather have those people go back to their original jobs as nurses or train as nurses?
Right.
Yes, would make a whole lot more sense.
Caretakers.
Right.
Yeah, yeah. But I also think there's a lack of training in sensitivity to patients too. People who are dealing with patients who are ill should have some type of sensitivity in their education, in their training, because sick people. I mean, you're supposed to cure the illness to save the patient. You're not supposed to attack the patient.
Right. I of course completely.
And there are so many personnel now who treat patients like objects to be turned and pushed or fed or changed or whatever, with no regard for their humanity.
That's not the kind of system we want.
No, absolutely not. And I think, of course, we have to take the profit out of it and come up with a system that welcomes people and pays people well enough and provides an environment that is conducive to caring for patients.
Right.
And giving and providing for their real needs.
I agree. I completely agree. I've been thinking about that more in terms of the doctor's role, doctor's ability to be focused on knowing and helping the patient. And one of the problems that my colleagues and I are talking about now is that in medical school, students learn about the importance of interviewing the patient, really getting to know the patient and understanding what's going on. But as they progress through training, there are fewer opportunities to do that and more reliance on kind of cookbook medicine. And there's a movement growing to allow the doctor to really focus more on the patient. Some people call it slow medicine, and some of us are working on that. That's separate from single payer, but also very important.
Right. And then there's another subject that I wanted to bring up with you, and that is racism in the system. Like I was just recently reading a piece in The Guardian that indicated that black men, for example, are 2.5 times more likely to die of prostate cancer, and they die at double 2.5 times the rate of whites. Studies were done in Chicago that indicate that black women and white women get breast cancer at approximately the same rates, but black women die at twice the rate. So racism is endemic, and there are many other illustrations that I could get into on how racial discrimination and segregation impact the health of black people much more.
I absolutely agree. And if you look not just at individual diseases, but if you look at all-cause mortality, so whatever cause of death, that you find the same kind of patterns that you mentioned. This is one of the great things about a single-payer health program. Part of what's going on in that racism is that poor people, African Americans, Latinos are much less likely to have insurance that gives them regular access to medical care. Mm-hmm. If you can fix that problem, you're headed in the right direction.
Right. Well, how do you think the single payer can actually deal with racism in the system? I mean, because after all, racism has to do with the attitudes and the practices of the personnel involved in the medical profession,
right,
and so on. So, but of course, an environment, and a more equitable environment would certainly lend itself to a less discriminatory,
right,
to less discriminatory practice.
Well, I think we want to, from my point of view, we want to start with what kind of insurance do people have. Right now, the poor people are more likely to be completely uninsured, mm-hmm. or to have Medi-Cal, which, as you pointed out, is burdensome administratively. And also, the payments that doctors receive from Medi-Cal are below cost.
Right.
So a doctor taking Medi-Cal is doing that on the basis of goodwill, not a business decision.
Right.
If you take away those two problems, so everyone has insurance and everyone has the same high-quality insurance,
right,
then I think that is definitely a step in the right direction. And I believe that attitudes about patients might follow. So if this isn't excusable, but if a doctor is impatient with African-American patients because many of them have been uninsured and things won't get paid, that's really not excusable. But I think it would potentially improve attitudes just if all the doctors, all the healthcare providers knew that anyone who came through the door was a regularly insured person. I mean, you probably know more than I do, much more than I do, about other issues in racism in medicine, but I would say I want to start with equalizing the financial footing.
Oh, absolutely. I think so. Yeah. And then, of course, struggling to change the attitudes. Also, as we were talking earlier, a lot of people seem to think that the ACA or Obamacare has solved the problem of Americans being insured. And I just Googled it, and according to the latest stats, there are 44 million Americans still uninsured and 38 million underinsured.
Well, I'm very disappointed in the ACA. When it was being proposed initially, if you recall, the first versions had a pretty large public option, is what they were calling it, which would initially the predictions were that maybe 80 million people would go into an equivalent to Medicare for all. But that was quickly cut out of the legislation, and in the end, there were very weak provisions for a public option. And as you and I were discussing before we went on the air, recently the few community plans that were put in place, the co-ops, mm-hmm. Those many of them went out of business because the rules and regulations were so restrictive and so onerous that they couldn't make a go of it in competition with the large private insurers. So, our initial hopes for what the ACA could accomplish were dashed pretty quickly and continue to be dashed. The ACA has increased the role of the private insurers, as we've talked about.
It was a gift to the
that
insurance
means they have
companies.
more profits, and it means we're wasting more administrative money. The number of uninsured hasn't gone down as much as hoped, but here's another very important consideration. Even those who now are insured are often underinsured.
Right.
They have high deductibles. Mm-hmm. They may have important services not allowed because they have, for example, a very restrictive physician network that they can go to, and if they want to see a gastroenterologist with a particular set of skills, they have to go out of network. As soon as you go out of network, you're paying out of pocket. Right. And so, there's some stuff that's come out recently from the Kaiser Family Foundation, and I recommend to viewers, if you want to see some of the best survey research on an ongoing basis on healthcare, including the effects of the ACA, look at the Kaiser Family Foundation. They just documented difficulties of people in getting care, onerous financial burdens from getting sick. This is among the insured, and this is increasing under the ACA. So sometimes people ask me, well, Dr. Khan, we know you favor single payer, but meantime, do you think an ACA is a step in the right direction? And I have to hesitate. I look at where it's pushed the system, and I'm not so sure it's a step in the right direction.
No, according to what I picked up, it said, let me just share this. Recently, some 500,000 people around the country suddenly lost their health insurance as 10 of 23 nonprofit healthcare cooperatives collapsed. Some 80,000 Coloradans were left in the lurch when Colorado Health Op collapsed. Nearly 40% of the people who purchased health insurance through the Colorado State Exchange in 2015 were members of that co-op. Okay? One of the individuals said, quote, "These tiny insurance co-ops were like the Pee Wee Football League going against the NFL. They just didn't have the size to make it in the marketplace. But also they weren't cheaters. The way the health insurance market works is good guys finish last and cheaters win. The way you make a killing in the health insurance market is by signing up lots of healthy people, collecting as high premiums as possible, and giving them as little health care as possible, And if they get sick, figuring out ways to force them out of the insurance. That's the way the U.S. insurance markets works. So then government grants to the co-ops were changed to government loans, which the co-ops would have to pay back. Not to mention that borrowing to fund reserves is a shell game. The net reserves are zero. So the GOP slashed funding even more than half and stopped the Obama administration from helping deal with the unexpected high costs of covering stick and so on. The bottom line is that it's not working because it was a gift to the insured. I thought as soon as I heard market exchange, I said, oh, forget it. This is a gift to the insurance companies.
Right, and I agree with everything you said. And, one of the ways that insurance companies avoid getting the sickest patients. Now, I should say that the ACA guarantees that everyone who's sick can get insurance, and they will pay the same amount as anyone in the community. That's called community rating. So that's good until the insurance companies figure out how to game the system. So, for example, how do you avoid getting expensive patients into your health insurance? Well, if they need lots of meds, you have strict rules about medicine access. Or if they need certain kind of specialists, you make sure that there are not enough specialists in your doctor panel to adequately meet demand. And then rumor spreads that, don't go to that insurance because you won't be able to see the doctor you need. Go to this other insurance. So as you said, they're in
they
there
can
to
cherry pick.
They cherry pick in very sophisticated ways.
I'm sure. But healthcare shouldn't be a commodity. It really shouldn't. A for-profit commodity. It's outrageous to begin with.
There's a word that a healthcare activist taught me a few years ago called disintermediation. And this is the great fear of the health insurance companies, that their business model is based on the idea that they are intermediaries between the people who are paying for the insurance and the providers. And as soon as we realize that we don't need that role, thank you very much, they will be disintermediated out of business.
Right, yeah. Well, we sure got a lot of work to do to make this happen. But also, I understand that one of the things that happened when the ACA was being negotiated in Congress was that they immediately took single payer off the table.
Right. So they literally didn't allow single payer proponents to participate in hearings, for example. I have some colleagues who are very respected, capable, thoughtful, progressive health economists who won't talk about single payer, because they've been told by the politicians in Washington that if you even mention single payer, you will not be at the table in D.C. for policy discussions. I mean, literally, you cannot talk about it. It's a gag order.
Why does that not surprise me?
And I think it's atrocious. So luckily, I've been, as you know, I've noticed, I don't shut up. And luckily, I've been able to do that. But other people feel, they kind of have to set the single-payer stuff aside for now.
Well, I hope you folks out there will make a New Year's resolution to speak up and demand single-payer health care.
Thank you. I completely concur. And keep your resolution.
Really? Make a New Year's resolution, for goodness sakes, because, boy, do we need to take care of this business. It's outrageous,
So I want to offer a couple of bright notes in this.
Okay.
One is that the recent U.S. polling, when you ask American residents how many of them support a government-sponsored system like Medicare to provide health care to everyone, more than half actually say yes. Now, of course, it depends a little bit how you word the question, but there is still a very substantial support for single payer. In fact, it was single payer was dropping in support a little bit, and it's now coming back up. I think people are realizing the limitations of the ACA.
Oh, yeah.
And some important public people, public intellectuals, thought leaders are now coming out in favor of single payer, people who are thought of as middle of the road. There's a very well-known physician and journalist by the name of Atul Gawande, who does some excellent writing on healthcare policy, and he's come out in favor of single payer. Most recently, a pretty middle-of-the-road commentator, very well-known, named Thomas Friedman, who's written on quite a few issues. He just came out yesterday in favor, or maybe today, in favor of single payer.
Wow.
So, he all the power to him. I don't think he's going to be gagged. No one can gag Tom Friedman.
Yeah, he's in a good position.
He's in a good position
to be able to exercise free speech.
Right. So, but when people who are considered thought leaders, middle of the road, they start to speak in favor of single payer, then maybe we're turning a corner. We're working very hard in California with PNHP, with California One Care, and other organizations to continue to educate and build support, to start challenging those Democrats who are not actively supporting single payer, kind of giving them a challenge from the left, kind of like the Tea Party challenged the Republicans from the right, to say, you don't want to support single payer, we're not going to support you. We're going to bring in other candidates who will. So this is a strategy that's developing over and be implemented over coming years. So we have not given up this fight. It's a tough fight.
It is a tough fight, and one of the things that is really messing with my mind is the temperatures plummeting, the terrible wet weather, and the 6,000 plus homeless people in San Francisco alone,
Right.
Suffering horribly and dying, because they're dying in this weather, and there's no health care for them.
Right.
What health care do we have for people who are out in the cold?
I mean, obviously, we have a public system. It's it's not a great solution. Seems to me there are issues beyond health care in that dilemma.
Exactly.
As well.
But I think what I'm trying to get at, Dr. Khan, is that we need to begin to connect dots.
Right.
Okay. We need to make connections between health and the provision of health.
Yes.
And what causes deteriorating health or poor health, disease, etc., the causes of that need to be also brought into the picture. For example, think about this. We have a healthcare system for profit, right? Now, this sounds diabolical, but it could maybe it's not thought out diabolically, but the provision of the provision of junk food, the prevalence of junk food, the food deserts in poor communities, also hazardous waste in poor communities that cause illness and asthma, increased asthma attacks, and so on. And then you also have, I lost my train of thought, but I think you're getting the picture that when you combine the things that cause poor health,
right,
the segregation, discrimination, poverty, homelessness, lack of education, lack of nutritional education,
right,
not knowing that food can be medicine,
right,
and not just pharmaceuticals,
right,
and so on. These things, it seems to me, have to combine, and we have to be thinking more holistically.
I agree with that, and I think one of the types of information that's coming out that's really helping us do that is the evidence about inequality.
Yes.
Income inequality and wealth inequality. And because so many of the things that you mentioned are associated with how much money people have.
Exactly.
There are two books that I've been reading recently that someone who's interested in a more in-depth look at that could look at. One's called The Great Escape by Angus Deaton, who's an economist who just won the Nobel Prize. And it's all about how far we've come in the last 100 years, but how far we have to go to rectify the inequality both in health and in income. And the other one is called The Health Gap by Sir Michael Marmot, who is originally Australian, trained over here at UC Berkeley. So we're proud to have him as a co-alumnus. And he wrote a book, The Health Gap, which is also a terrific look at these issues. You're absolutely right. These are tied together. And aside from providing health care for everyone, we need to help everyone have the kind of financial security which will foster avoiding these problems. You don't want anyone
foster good health.
Foster good health, and more than good health, but just full enjoyment and full ability to prosper.
Right. Yeah. And also, we have food deserts all over the place,
right,
where people can't access healthy food,
right,
and that's nuts in a society as wealthy as this.
Right.
Yeah.
Yes, I understand. I don't know much about that issue. I heard that I read one example of a big supermarket that opened up in a food desert, and they did great. So hopefully we'll see more of that.
Yeah. And I've read stories like I read the New York Times, and I remember reading about this woman who had to travel, literally get on a bus and travel quite a distance to get to a supermarket. There was just nothing in the neighborhood.
Right.
So those are some of the things. But one of the other thing I wanted to bring into the question is single payer. Will that embrace or include dental care?
It will in California. That's the plan. There are different versions of single payer in different places, and they don't all include. But that's the plan now. I have to say, we need to fight for this.
We sure do, because dental care is very important.
I'm a great believer that eating is important to our health, and I believe that requires teeth most of the time.
It helps to have them.
We're gonna. There are a variety of what are oddly enough considered non-vital or non-core services, long-term care, dental care. Certain other kinds of services, and I think it's really important as we move forward on single payer that we get the broadest coalition saying no, we're not going to trim away these so-called non-essential services because they are essential.
Yes, they are. I had a helper recently who was suffering Medi-Cal cutoff dental care, so she was suffering horrendously from an abscessed tooth. And every time she went to general, they gave her more pain pills because she wasn't covered, and it was going to take her a while to be covered under IHSS. It was going to take months. So she just was having horrible. She couldn't sleep. The painkillers didn't work. She was just miserable until a friend helped her out financially, and she was able to get the care, pay out of pocket and get into a little financial debt to cover it. But she was just in horrendous pain, and multiply her by how many people who suffer from a lack of dental care.
It's inexcusable.
It is.
I'm lucky enough to have a steady job and dental insurance, and I've had a couple of root canals for exactly that problem, and it's the best procedure in the world, but everyone should have access to that.
Exactly. It's crazy what they're doing now to poor people. I mean, they're just not letting us, and also they cut off eye care.
Another thing which is optional. I mean, why do you need to see anything?
So, I mean, here we have, a most inadequate healthcare system as it stands.
Right.
So I'm wondering if, and I'm a recipient of Medi-Medi, so I'm very aware of its limitations. But so I practice prevention as best I can.
Sure.
But I'm also very careful about medicines. And I can proudly say I'm not on any drugs.
That's excellent.
And I bet you're surprised, aren't you?
I am surprised for someone who has had a tough medical history like you.
Exactly. And every time I go to any doctor or medical facility and they ask me to give them a list of the drugs I'm on, they're always shocked. Because for one thing, for example, I'll give you a perfect example of why I'm not on drugs. I recently had went through a lot of stress and had was hospitalized for 3 days I had my heart palpitations where my heart was racing. And I knew it was stress. So they kept me 3 days, and the doctor gave me a prescription for something that starts with a mono something, but it's a heart prevention medication, heart attack prevention medication. I'd never had any heart problems in my life. The prescription was for 25 milligrams once a day. I took it for a month, and when I went for a refill, it had refill on there. The pharmacy couldn't find the doctor for several days. So when he finally called me, I was off the medication. I said, I don't need this stuff, So I said, oh, well, maybe I should get it. When they finally called and it was ready, I said, well, maybe I should take it just to have it on the side, but I'm not going to take it anymore. And when I looked at the medication, Dr. Khan, I couldn't believe it. They had actually doubled the dosage to 25 milligrams twice a day.
I wonder why they did that.
And I didn't even need the medication. But this is not the first time I've encountered doctors giving me medications I didn't need. When I was hospitalized in long-term care facility, I used to check my medications carefully. And I would confront doctors, and why are you giving me this? Right. They'd give me medications without even notifying me.
Right. Well, this goes back to what I was mentioning earlier about giving doctors a better chance to really get to know patients and not just go by cookbook medicine, not just throw diagnoses and medicines at patients.
It's terrible what they do.
And there's a wonderful book written by a colleague of mine called God's Hotel, which is about the transformation of Laguna Honda Hospital in San Francisco.
That was a nightmare.
Victoria Sweet, who's a doctor who teaches at UCSF, wrote this book, and she tells a wonderful story about a patient that came to her who wasn't as smart as you, had 18 meds and 9 diagnoses. And Dr. Sweet got to know this patient, and over the course of some months, carefully, one by one, reduced all the meds and all the diagnoses. I forget. I think in the end there was one diagnosis left and one medicine or something like that. But this person went from being sort of a medical zombie to being great and going home.
Right.
And you're smart to not let them pile up. I think it's too easy to write a prescription sometimes.
That's what they do.
Right.
And that's unfortunate for. And then the other thing, talk about like just recently, this drug for, I think it was a cancer drug, was $13 a pill, and this I'm trying to think of a word to describe him, but I'll just call him a
objectionable character.
Okay, that we can say that on
That'll
the
pass
air.
muster with the censors.
Yes. Increased it to $7,000 a pill.
Right.
But he was later busted for fraud, and I was.
This fellow is a bit unsavory.
Wow.
And figured out a way to corner the production of this pill and then basically use his temporary monopoly power. It's just
it's disgusting.
It's nasty.
Yeah, and Big Pharma is nasty too. Like this Hepatitis C drug. Why do they have to charge that kind of money? And then they don't allow generics. And I understand that in Egypt they've already administered the drug as treatment to hepatitis C patients all over Egypt for $10 a pill.
Well, so I know a little bit about that story. I actually just published some research on that, and I have a slightly different take on it.
Oh, okay.
First of all, I do agree that the price is way too high. So I agree with that. But I know the company's actually been working actively with the Egyptians to get that 99% price reduction right off the bat. So that's why it's $10 a pill instead of the amazing number of $1,000 a pill. So I think there are real issues here in how we should price drugs, and I think $1,000 a pill is kind of ridiculous. I will say that the drug is amazing; it's curative, and that the company, even before they made it available in the United States, was already working with other governments, like in Egypt, to get those discounts in place. The same company developed an HIV drug some years back, and it took a lot longer to get the low prices for poor countries. The good news is that the low prices for poor countries were very quick to happen this time. Last time they took 3 or 4 years. This time it's instant. So I confess I think that story is a little bit more complicated.
Right, but they did get a 99% reduction.
They did, and I think that was really important. And I think.
Well, how could we do the same here?
Well, the problem is, of course, I don't know exactly what the right price is. It's got to be something less than $1,000 a pill. Here's my ambivalence on this one. The U.S. drug industry usually focuses on Me Too drugs, so another drug that's pretty similar to what exists and doesn't really add a whole lot of extra benefit, and then they charge a lot for it. So this particular drug that we're talking about, these new antiviral drugs for hepatitis C, are transformative. They take a disease which is basically permanent and chronic for them, or what's known as a monopsony. When you have a monopsony, that buyer has a lot of power. That buyer can negotiate much lower prices.
Oh, okay.
And so that for sure will happen.
Oh, okay. Well,
that'll help.
That sure would, I'm sure, because the pharmaceuticals today are just egregiously exorbitant.
Right. I agree. And another problem with the current system is that the generic drugs that used to be pretty cheap, sometimes now the companies are cornering the market, cornering the production, and they're increasing the prices. Even aside from that egregious example we talked about a moment ago, this is increasingly we're seeing the generic drugs going up in price, and under single payer that just wouldn't be permitted.
Oh, good. Okay, so that's all the more reason we should fight for single payer to reduce the cost of pharmaceuticals.
Well, that's our New Year's resolution, isn't it?
Oh, yes.
Okay.
Yeah. Okay, so folks, let's be... Oh, a report came out I was listening earlier. We got about 2 minutes, or less than 2 minutes, but a report came out earlier on the news hour or something that people actually feel a lot better, and they did a little scientific study, feel a lot better giving than they do receiving. And
I completely agree. There's research that as our income goes up, initially as we go from poor to middle income, we are happier. We are less worried about paying the bills. But after a certain point, more money doesn't make us happier. But what makes us happier is getting involved in a community effort, a community organization. So that's a kind of giving which I'm greatly in favor of.
Right on. And thank you, Dr. James Kahn, of Physicians for a National Health Program. Thank you so much for joining us here on Freedom is a Constant Struggle. It's been a pleasure.
Well, thank you very much for having this great show and for inviting me.
You're welcome. And thank Andrew Montoya for board hopping, and thank you, viewers, for tuning in to Freedom is a Constant Struggle. We'll be back on January 21st to honor Dr. Martin Luther King. Take care.